My name is Dana Simon. I'm a practicing anesthesiologist and pain medicine specialist in Des Moines, Iowa. And I'm honored to speak with you and for you today. And I'm not speaking as a designate from the ASA or ASRA, and this is part of my disclosure. The guidelines are an update from the 1997 guidelines. And as you may know, the Institute of Medicine, as Dr. Mgmt has pointed out, has asked for more guidelines to be done. Now you have to understand that you're looking at somebody who believes in guidelines. But I want to specify why, and during the talk I'll go into it. My point is that if we don't have guidelines, someone else will set them for us. It'll be worse than any of the guidelines that our different societies are coming up with. Evidence-based guidelines have been around for a long time. As anesthesiologists, since the time of dental anesthesia, how to apply ether. Guidelines have always been there, and they will always be there. They're practice guidelines, and one of the topics that you'll hear today is about the warfare in this area. I hate to hear that, because that to me perpetuates this ideology that everybody is evil, that consultants are all evil. And while I agree with some aspects of Dr. Mgmt's talk about the monies that are inappropriately diverted, I think the intentions are good from the vast majority of us, and hopefully not to proceed in a naive fashion. So they're practice guidelines from the American Society of Anesthesiology and ASRA. They're comprehensive evidence-based guidelines for interventional techniques by Dr. Mgmt also. And we see the interventional therapies, surgery and interdisciplinary rehab that was published by Chow and Lozier. And these are competing, if you will, guidelines. If you look at them this way, I tend to look at them more as taking the best out of what they say. And there are differences in the way these are analyzed, certainly. And there are differences in the way that we should look at them. The purpose of the ASA and ASRA guidelines was to validate and optimize effective pain treatments, to identify allied multimodality therapies, and improve functional and psychological capabilities of patients that we see every day, to improve their quality of life, and to minimize adverse outcomes, which I think is extremely important for all of us, and we all recognize that. These guidelines did not address pediatric pain, cancer pain, acute postoperative pain. They didn't address headaches. They addressed chronic pain or pain which should not heal within the spectrum of normal tissue healing. And I think that's important to realize. Anesthesiologists, as well as pain physicians in various specialties, can benefit from these guidelines. They're a resource for physicians and nurses engaged in the care of patients with chronic pain. And I want to emphasize, and as stated, you'll see on page 811, section D, these are not intended to provide treatment algorithms for specific pain syndromes. They're not to be inappropriately misappropriated by insurance companies or other parties to mandate what we should or should not do. And I think that this is a huge area in which we've not been vocal enough as doctors and allied healthcare workers. On this task force were 12 members representing a diverse community of academic and private practice physicians, anesthesiologists from different geographic locales. There are 2 consulting methodologists who have a wealth of experience in doing guidelines and even comparative guidelines research. The review covered 56 years and over 5,000 different articles along 8 different linkages, such as electrical stimulation, botulinum, and acupuncture, and so forth. This study took 3 years. It was done over a period of 3 years. Expert opinion was obtained Then we solicit opinion of both ASA and ASRA members through surveys. There are open forums, 2 such open forums, World Institute of Pain and the American Pain Society. There are internet postings, and the process involves 7 steps and 8 linkages. And I want to bring up in your booklets, if you have your booklets now, the second half of this. It's hard to cover 3 years in 30 minutes, but in the second half are all the scientific analyses of how this was conducted, and you'll see those included in your handout. The process involves 7 steps, which to establish criteria for the evidence to begin with, to collect the original peer-reviewed research, to gather expert consultant opinions, and then there were solicitations of opinions on this draft from ASA and ASRA members on the draft as it first presented. Task forums were then held, as I noted, at the World Institute of Pain and at the American Pain Society meeting in San Diego in 2009. Consultants assessed the opinions on the feasibility of the guidelines, and all available information was then used to build the consensus to finalize these guidelines. I want to emphasize one thing, and that is that these are guidelines. And for those of you who are familiar with the movie Pirates of the Caribbean and saw it, where Elizabeth is taken from the town of Port Royal and is on the Black Pearl, and Captain Barbossa says, well, first she says to him, I demand essentially to be taken back to the town of Port Royal. And he looks at her and he says, first of all, that was not part of our agreement, and therefore you will not be put ashore. Secondly, these guidelines, these rules are applied to people who are pirates, and you're not a pirate. And thirdly, the code is more what you call guidelines and rules. And I think that that's important for us to understand, is that these are not rules for conduct, and those who say that they are wrong. And the insurance companies cannot say these are rules, and these are also not algorithms or specific algorithms for treatment. If you read the first and second page of the guidelines by ASA and ASRA, it specifically states that these are not to be utilized, that alternative treatments and modalities can be used by any physician or any practitioner, and that the guidelines are only suggestions. And I think this is extremely important to know and might ease someone's angst and anxiety regarding them. Much like grade school, these are graded from A to D, with A being randomized controlled studies, B being suggestive literature, C that which is equivocal, and D, insufficient, and I'll get into that. And Dr. Mgmt talked about that a little bit. For example, insufficient evidence is found for sacroiliac joint injection with regard to pain relief. It's level D. Does that mean that we shouldn't be doing sacroiliac joint injections? The answer is a hearty no. We should be doing them in the appropriate patients. We just don't have the literature to support it. That doesn't mean it cannot or should not be done. And I think that this needs to be emphasized. So you have randomized controlled studies, multiple RCTs, through which meta-analyses were done for level A1, level A2. There were not enough studies to justify a viable meta-analysis, and A3 would be, for example, a randomized study and a case with a case report. So B is suggestive, C equivocal, and D insufficient literature. And I want to go through the 3 main categories that the ASA and ASRA looked at this in terms of the flow in which we naturally see a patient. We see a patient through patient evaluation, then we look and see the specific specialty we practice, should it go to another practitioner. And we looked then at single modality interventions, which I think represents a majority of us here today, are single modality interventionalists. From the standpoint of patient evaluation, the findings are that with suggestive evidence, which is high level of evidence, history and physical examination are essential tools. I don't think anybody would disagree with that. The literature fully supports that. It's important to document this. Looking at the sensory and affective pain components and also the psychological pain component, Also, B2 level suggestive level of evidence in the literature does exist. And then task force experts and members of the ASA and ASRA looked and found that the causes and effects of the pain, physical deconditioning, occupational status, psychosocial dysfunction, and evaluation is extremely important and may be responsible for some of the areas in which even our interventions are not working at all. We should identify anxiety, depression, and anger. Many of us know this already, but to have it formalized in the form of guidelines, I think is extremely important. Activities of daily living assessment is important. Influence of pain on mood, ability to sleep, addictive or aberrant behaviors, interpersonal relationships all affect response to pain. The importance of multimodality or multidisciplinary interventionalists. I don't know how many of us are here, practice in a multidisciplinary or true multidisciplinary environment, but this was also looked at, and extremely high evidence, level A evidence with randomized controlled studies, reducing the intensity of pain for up to a year. Of course, there are multiple collaborations that we have with anesthesiology, pain medicine, physiatry, orthopedics, neurosurgery, neurology, rheumatology, psychology, psychiatry, pharmacology. All of these together are very important, and there is evidence to support their utilization. Most of us are involved in single modalities, and again, there are 8 linkages that I mentioned. They're in your slides in the addendum, along linkages of electrical stimulation, botulinum, acupuncture, long-acting opiate medications are all in the linkages. You'll see them there in your text. Randomized controlled studies show that fitness and exercise relieves pain for 2 to 18 months, level A2. I don't know how many of you in the audience are runners or like to exercise, but I think that a lot of our presenters run and exercise, a number of them that I know. And what better modality to treat pain than to keep fit? And prevention of pain is extremely important. Level A2 evidence for this with physical and restorative therapies. Cognitive behavioral biofeedback, relaxation training, relief of low back pain for 4 weeks to 2 years. Level A2 evidence again, and that's a strong supportive evidence that it works. In other words, that we should be sending the patients for assessment prior to spinal cord stimulation, that this is reasonable, for example. Case reports suggested that supportive psychotherapy may assist also in chronic pain management. Level B3 evidence that this is reasonable. In case reports that this is highly suggestive that its utility is well demonstrated. How about electrical nerve stimulation? We've got meta-analyses showing effectiveness for TENS, level A1 evidence, and for lower back pain, and for other conditions, 3 to 6 months. For spinal cord stimulation, the studies that compared spinal cord stimulation with physical therapy versus physical therapy alone, some of the studies by Kemmler, who I'm sure many of you are familiar, A3 level of evidence on that. Spinal cord stimulation versus reoperation, many studies by North and others, showing that spinal cord stimulation versus reoperation. Spinal cord stimulation certainly is considered preferred by many to reoperation, with 6 months of pain relief demonstrated. Now, it doesn't mean it can't last longer. Again, cannot last longer just because it showed 6 months of pain relief. It can go for years, but that's what the literature shows. And so this is extremely important, not to take these little niche statements as verbatim fact. And I think this is the point what Dr. Machikati was talking about also, is that the construction and interpretation of these sometimes it's not like concrete. And I think this is something that has to be looked at very carefully. Utilization for peripheral neuropathic pain, postherpetic neuralgia, peripheral vascular disease, and then we look at it for peripheral nerve stimulation. suggestive evidence, which is still very high level of evidence, that it works for pain relief for 4 to 24 months, and utilization for peripheral nerve injury is indicated here in addition. Many years ago, this is just a slide which I had saved for those of you, and I don't know how many are non-invasive or at least looking into this area, but this is a stimulation lead going up to TAT9 level in a patient with right lower extremity pain, and a lateral view of that just to demonstrate some of the things we're talking about today. Radiofrequency ablation, of course, work of Bogduck, Lord, Barnsley, and others over many years now. Lower back pain patients, lower back pain scores for 2 to 6 months, level A1 evidence, the best level evidence for efficacy for radiofrequency ablation. I mean, I think we should be very happy about this. People say, well, why should we have guidelines? This is one of the reasons that guidelines are useful, because they do confirm the efficacy of this through the sometimes limited literature which we have. We don't have unlimited dollars. It's difficult to get institutions together to collaborate on a large N number of patients to demonstrate efficacy. And to have this type of literature available to show efficacy, I think, is invaluable. Randomized controlled studies of neck pain patients showed relief for up to 6 months, level A3 evidence. Water-cooled RF, some of the studies by Cohen and others, lower pain scores for 3 months, level A3 evidence for chronic SI joint pain. How about pharmacological management? And I always like to start with the A's, much like others were talking. You know, it's nice to know what it really is supported and well supported in the literature. If you look at the alpha delta 2 calcium channel antagonists, certainly some of the older work by Baconia and others, you'll see effective pain relief for 5 to 12 weeks, level A1 evidence. Sodium channel antagonists, 2 to 18 weeks for A1 level evidence there. Some of the work by Mitchell, Max, and others with tricyclics, relief for 2 to 8 weeks. And for a variety of pain conditions, neuropathic pain, and a variety of other conditions these are utilized for. I think that's very important. Now, does that mean it only works for 2 to 8 weeks? No. These can work for months. They may work for years. But that's what the literature shows is effective based on the reports and studies that we have. Non-steroidal analgesics, 2 to 12 weeks of lower back pain relief in randomized controlled studies with placebo controls, level A2 evidence. How about the extended release opiates? This has already been talked about earlier this morning. This is certainly a huge area of concern, both in the utilization, misuse, abuse, and so forth of these medications is utilized for chronic pain management. 1 to 9 weeks is what we could find with the meta-analyses of relief for lower back and neuropathic pain with A1 level evidence. Excellent evidence for that, but that's it, 9 weeks. Can it work longer? Yes. Do we have the data to support it? Not at that level of support. Tramadol, 4 to 6 weeks of pain relief, level A2 evidence, and observational studies showing up to 3 months of pain relief for immediate release sublingual transdermal opiates for lower back, neck, leg, and neuropathic pain with suggestive level of evidence at that with the other preparations, not the extended duration. Pharmacological management, NMDA receptor blockers, we're all familiar with the use and abuse of these, dextromethorphan, cough syrups, and so forth. NMDA receptor blockers, 2 to 16 weeks of pain relief, B2 level of evidence. But there's only equivocal evidence, this level C evidence based on the reports, that it can help with diabetic neuropathy, neuropathic pain, or complex regional pain syndrome. Now, to me, if it's equivocal evidence, and people say, well, what's the use in all these guidelines? What purpose do they serve other than wasting trees and internet time? You know, I look at this and I look at the equivocal nature of the utilization with CRIPS, and I look at somebody maybe has a bad foot from complex regional pain syndrome, who may be morbidly obese and has sleep apnea, and I say to myself, methadone's an NMDA blocker. You know, Do I want to use methadone in that patient, knowing that there is a very significant increased morbidity and even mortality from utilization of this, perhaps due to our collective ignorance in its pharmacokinetics, pharmacodynamics, and effects on this particular patient, and maybe with a little ignorance in the way it's prescribed? No, not necessarily. I'd probably think 5 or 6 or maybe 10 times about it before I did it. Maybe I'd start them on a different series of pharmacological agents or interventional procedures, better yet, for complex regional pain syndrome. And I think this is the value of guidelines too, is to really look at the levels of evidence that's out there, as controversial as they might be at times, and decide the appropriate treatment on that basis. Benzodiazepines, evidence for pain relief up to 2 months, level B3 evidence. I don't know how many of you use Valium or other medications, benzodiazepines, constantly in your practice, but I would say that the consultants that we surveyed were certainly equivocal about it. I personally do not use benzodiazepines except in very selected conditions with chronic pain patients. SSRIs show equivocal efficacy for diabetic neuropathy, and for skeletal muscle relaxants, there's insufficient literature. Again, does that mean they don't work for chronic pain conditions? Not necessarily. It's just that there's no literature out there that we could find to support its use. Topical agents were also looked at. Randomized controlled studies, placebo-controlled or equivocal for peripheral neuropathic pain, whether it's capsaicin, lidocaine, or ketamine, and diabetic neuropathy. Observational studies did show 3 to 6 weeks with a suggestive application or level of validity. So these agents are used, can be used, and but there's the randomized controlled studies are only equivocal. And by the way, I don't think that randomized controlled studies are necessarily always the best thing around. I'm skeptical of some of the RCTs that are done. I don't believe in their placebo component sometimes, which is not really placebo, or it's inappropriately constructed. And I agree that sometimes the people doing these studies, not the people who are knowledgeable about them, which is another unfortunate circumstance. Botulinum toxin with pyriformis syndrome, we had a rash of reports many years ago about its efficacy and application for this. ASA members and survey of ASRA members did not support its routine use, equivocal findings for myofascial pain, but there have been some reports and randomized studies showing efficacy for some months. How about epidural steroids? Randomized controlled study of epidural interlaminar injection, reduced pain scores at 6 months for leg pain, A3 level evidence, but equivocal for back pain, only equivocal level of evidence when epidural transfemoral is compared with saline. Now, there was a study, I think, by Karpinen in spine back in early 2000 time frame. So we do have a trend now where epidural steroids are showing perhaps better efficacy and application for radicular pain syndromes, and not necessarily for axial pain, although I think the jury is still out on this, and I happen to agree with some of the criticisms that were aimed before. I think a lot of the epidural studies are ancient, old, were incorporated, and not really valid. They weren't done with fluoro, and yet they're still incorporated into our thinking and ideology today. That's my personal bias. Now, if you look at RCT compared with the parasagittal interlaminar approach with a transforaminal approach, I think there's a study by Candido which studied contrast media flow, primarily was its main intention. Equivocal pain scores for lower back pain, C2 level of evidence, although this was an interesting study in terms of a comparison of effectiveness, I thought. Epidural steroid injection with or without local anesthetics may provide 2 weeks to 3 months of pain relief. Neck pain can be relieved for 1 to 12 months with these on a suggestive level of evidence. And basically there have been complications reported, as we're all aware, of dural puncture, infection, cauda equina syndrome, neurological deficits, death. Rathmel, certainly, as you're all aware, I think, has published on this. I think even Dr. Huntoon had an article back in '04, I believe, on transforaminal triamcinolone. I mean, these are very, very serious issues, and the question is whether they're worth doing sometimes, knowing that a high percentage of cervical conditions and others may dissipate with other forms of therapy. And so shared decision-making is recommended here. When we speak to a patient, if there's a newer development in the guidelines, it is that we should really be discussing these things fully and openly with our patients before we bring them into the procedural room, that they should be aware that there are alternative techniques and it should be documented, that we should think about whether we want to do a transforaminal or other approach and why. And the image guidance is recommended for transforaminal, and there is some suggestion that may be considered also for dorsal interlaminar approaches in this regard. So shared decision-making, again, is extremely recommended, and as somebody may bring up, even the Institute of Medicine, one of the defects in a lot of the guidelines is that where's the patient input? Where's the patient input in the process? And I think we'll see that change in the future. Also, diagnostic nerve blocks, relief of pain from 1 to 14 days. Diagnostic nerve blocks, peripheral or other, can help determine the location of pain. I don't think this is news to anybody. And so from that standpoint, the suggestive level of evidence. But again, it's nice to have this documented in the guidelines. Somebody comes up to you and says, what is the reason that you're doing this particular procedure on this nerve for this purpose? You can go to the guidelines and say, hey, this is a suggestive level of evidence. It helps support the practice. And I think we're going to see more of this rather than less of this in the future. And if it's done right and looked at in the right way, it's helpful. Cervical facet joint pain treated with medial branch blocks, higher specificity than sensitivity. In other words, the result is a positive result from the injection, and the patient really does have the problem. That is specificity, whereas the other way around is for sensitivity. So a higher level of specificity, certainly, but very good positive predictive value for medial branch blocks, again, worked by Bogduck and others, Susan Lord. Facet joint injections, equivocal evidence for RCT versus saline, and yet improved pain scores on observational studies, B2 level of evidence, and there is some support for the pain relief afforded with simple medial branch blocks. Observational studies showing many months of pain relief, and comparison with placebo in that regard not found, and so as of yet. Positive predictive value of sacroiliac joint injections up to 72% for identification of the joint, and yet the treatment for relief of pain is insufficient evidence. I talked about this before. Does that mean we shouldn't be doing sacroiliac joint injections? I think the state of Illinois, for example, to my knowledge, has refused to cover SI joint injections, or insurance companies from that state. I find that to be egregious. I think that sacroiliac joint injections are very, very helpful. A level evidence of D, it doesn't bother me. I would say that that simply shows what the literature shows, that the literature that we've reviewed and looked at shows. And there are patients who have positive provocative testing, have sacroiliac joint pain. And of course, if you looked in the vendor section today, there are all kinds of even surgical devices for sacroiliac joint stabilization, and a high incidence of SI pain in patients who've had lumbar fusion or other fusions, for example. So this to me is a very well-known issue. And again, this is just an injection some time ago, that showing the spread both posteriorly and anteriorly in a patient with SI joint pain. Discography, provocative discography, is up to a 60% positive predictive value. This is an area of controversy in our specialty, as many of you know, with some of the classic work by Darby and others being done. I think that the issue of discitis, epidural abscess, and embolization has been noted, level B3 evidence. I also wanted to bring up some of the minimally invasive spine procedures that are done in the spine. In that regard, is one of the areas that was looked at by the ASA and the ASRA guidelines. So that kyphoplasty, for example, and vertebroplasty both share B level of evidence and lasting up to 12 months. and also procedures such as nucleoplasty and decompression sharing the same B2 level of evidence for efficacy. Both are recommended in the appropriate selected patients, but again, with regard to discography itself, these should not be used in the routine evaluation of a patient's chronic nonspecific back pain. They're not intended to be done once a patient walks through the door. They're to be done very specifically and usually at the, after a lot of thought and investigation into the patient's condition. Intrathecal drug delivery systems also looked at, intrathecal opiates. Observational evidence intrathecal opiates provide effective pain relief for 1 to 12 months. B2 level of evidence, and zinconitide can provide up to 48 hours of pain relief in patients with refractory neuropathic pain. Very good evidence for these in general, and certainly we're familiar with their application. I'm also familiar, unfortunately, with pockets of the country where some of these patients are also taking oral opiates, and I think that the expertise of the individual is very important here. Acupuncture, C1 level of evidence for efficacy. Observational studies show 6 months, 1 week to 6 months of pain relief. And in conclusion, what I want to say here is that these are guidelines and that these are not rules. I think we have to carefully think about what resonates between you and your patient. That these guidelines do not dictate what you should or should not do. These guidelines are there to support practice and that they're there to help. Many gaps in research remain, and these are opportunities for us, not the otherwise. These are opportunities for us to improve these issues in the future. This is a very short time frame to discuss 3 years of work. I could discuss this for a very, very long time still, and I'd be happy to do so if any of you have any questions to the web address that's indicated here, mcadoctors.com. It was my pleasure speaking to you today, and thank you very much. Various specialties can benefit from these guidelines. The resource for physicians and nurses engaged in the care of patients with chronic pain. And I want to emphasize, and as stated, you'll see on page 811, section D, these are not intended to provide treatment algorithms for specific pain syndromes. They're not to be inappropriately misappropriated by insurance companies or other parties to mandate what we should or should not do. And I think that this is a huge area in which we've not been vocal enough as doctors and allied healthcare workers. On this task force were 12 members representing a diverse community of academic and private practice physicians, anesthesiologists from different geographic locales. There are 2 consulting methodologists who have a wealth of experience in doing guidelines and even comparative guidelines research. The review covered 56 years and over 5,000 different articles along 8 different linkages, such as electrical stimulation, and botulinum, and acupuncture. The interventional therapies, surgery, and interdisciplinary rehab that was published by Chow and Lozier. And these are competing, if you will, guidelines. If you look at them this way, I tend to look at them more as taking the best out of what they say. And there are differences in the way these are analyzed, certainly. And there are differences in the way that we should look at them. The purpose of the ASA and ASRA guidelines was to validate and optimize effective pain treatments, to identify allied multimodality therapies and improve functional and psychological capabilities of patients that we see every day, to improve their quality of life, and to minimize adverse outcomes, which I think is extremely important for all of us, and we all recognize that. These guidelines did not address pediatric pain, cancer pain, acute postoperative pain. They didn't address headaches. They addressed chronic pain or pain which did not heal within the spectrum of normal tissue healing. And I think that's important to realize. Anesthesiologists, as well as pain physicians, My name is Dana Simon. I'm a practicing anesthesiologist and pain medicine specialist in Des Moines, Iowa. And I'm honored to speak with you and for you today. And I'm not speaking as a designate from the ASA or ASRA, and this is part of my disclosure. The guidelines are an update from the 1997 guidelines. And as you may know, the Institute of Medicine, as Dr. Mgmt has pointed out, has asked for more guidelines to be done. Now you have to understand that you're looking at somebody who believes in guidelines. But I want to specify why, and during the talk I'll go into it. My point is that if we don't have guidelines and so forth, this study took 3 years. It was done over a period of 3 years. Expert opinion was obtained. Then we solicited opinion of both ASA and ASRA members through surveys. There are open forums, 2 such open forums, World Institute of Pain and the American Pain Society. There are internet postings, and the process involves 7 steps and 8 linkages. And I want to bring up in your booklets, if you have your booklets now, the second half of this. It's hard to cover 3 years in 30 minutes, but in the second half are all the scientific analyses of how this was conducted, and you'll see those included in your handout. The process involves 7 steps, which to establish criteria for the evidence to begin with, to collect the original peer-reviewed research, to gather expert consultant opinions, and then there were solicitations of opinions on this draft from ASA and ASRA members on the draft as it first presented. Task forums were then held, as I noted, at the World Institute of Pain and at the American Pain Society meeting in San Diego. Someone else will set them for us. It'll be worse than any of the guidelines that our different societies are coming up with. Evidence-based guidelines have been around for a long time. As anesthesiologists, since the time of dental anesthesia, how to apply ether. Guidelines have always been there, and they will always be there. They're practice guidelines, and one of the topics that you'll hear today is about the warfare in this area. I hate to hear that, because that to me perpetuates this ideology that everybody is evil, that consultants are all evil. And while I agree with some aspects of Dr. Mgmt's talk about the monies that are inappropriately diverted, I think the intentions are good from the vast majority of us, and hopefully not to proceed in a naive fashion. So there are practice guidelines from the American Society of Anesthesiology and ASRA. There are comprehensive evidence-based guidelines for interventional techniques by Dr. Mgmt also. And we see